Some say old age is mind over matter. If you don't mind, it doesn't matter. But what about the aging mind? How does it change? And how much does it matter? Find out now on AgeWise. Hello, I'm Ed Rosenberg, Director of Appalachian State University's Gerontology program. Welcome to AgeWise. Many things change as we age. Many are positive, but some are negative, and some changes involve the mind, perception, memory, emotions, relationships. Some older adults have difficulty dealing with these changes, which can create anxiety, even fear. And often their middle-aged children don't know what to do or how they can help. But what is the reality of how our psyches change as we age, and what is merely myth? Our guests on this edition of AgeWise have some answers. Lisa Emery is a professor in Appalachian State University's Psychology Department. Murray Hawkinson is clinical director at Daymark Recovery Services. Welcome to AgeWise to both of you.
Hi.
Thank you. Nice to be here.
Lisa, let's start with you. You're an academic psychologist and you study aging and older people. What exactly is the psychology of aging?
So psychology of aging, much like all of psychology, kind of has two major divisions to it. There's the division I'm in, which is more experimental, and there's the division that Murray is in that is more applied. So speaking of my research, my work, I'm an experimental psychologist. I do research on basic processes that change and how they change with age. So much of my research is on memory processes and what's normal, what's kind of typical with aging.
Do you teach courses that have to do with
I do.
psychology
I teach
of
a
aging?
psychology of aging course, kind of two versions of it. One that's aimed at students who are going into medical fields, and another version of it that's aimed more at our budding psychologists, our undergraduate psychologists.
And Murray, you're a psychotherapist. Some of your clients are elderly, or you work with adult children who have issues about aging parents to talk about. What does your work entail, and how is it different from what Lisa does?
Well, it is applied, as she was saying, and I think actually there's a couple different aspects to what I specifically do. One is I'm an administrator for a mental health system, and I also do some private work, so I can kind of keep my chops up about seeing people and being helpful. And it's primarily in the private work at this point that I actually have clients that I see on a regular basis. I do a group in Daymark that's mixed ages, but not specifically with older folks.
So again, how would you describe the difference between your two approaches? You're an academic and a researcher,
Yes.
and Murray is more in the practice field.
Yeah, that's what I would say. And I always like to emphasize that I'm not a trained clinical psychologist, and so I'm not trained to work with people in an applied setting, people who have mental health problems. What I do instead is I research what's kind of normal and typical with aging, and teach about what's normal and typical and how we discern that from what's atypical or abnormal.
And, my position is to be a consumer of the research that folks like Lisa generate. So, we try to stay in touch with what the findings are, what the research shows in terms of trends and issues and so on.
So it's almost, I have to say this because I have sons who are natural scientists, hard scientists. It's almost like my one son who's in physics, and he does a lot of the theoretical work, and you're more like my other son who's an engineer, and he takes that theoretical work and puts it into practice and makes sure the spapeships aren't going to crash.
Yeah,
Yes,
that's
that's a good description.
Okay.
And I think one of the difficulties with psychology is that both of us are called psychologists, whereas your sons are physicists and, I'm sorry, I forgot what your other son does, but there's different names for those things. And I think calling us both psychologists, that's what we are, but sometimes confuses people who aren't familiar with psychology.
Mm-hmm. Murray, how do older people feel about coming to psychotherapy? Do they have different attitudes toward it than younger people do?
I think sometimes, it's all very individualized, really, because, there are certainly young folks who are willing and able and enthused about that kind of thing, and other folks who are just really not interested at all. And same with folks of older age. Some of them truly believe that this is a perfectly acceptable, desirable thing to be doing for themselves. Some have been urged to seek counseling by their primary care physician, by a family member, and they may come in more kind of a unwilling position. But, that again is true across the age range as well.
But some people do feel that there are generational differences in whether a mental health issue or seeing a counselor or a psychotherapist for that issue is stigmatized or not. Do you feel there are those generational differences, or
I think so. I think that people who are more advanced in age, my age and so on, come from a different approach in society's view of what mental illness is about, what it represents, whether it's moral failure, whether it's religious lack of faith, whether it's this or that. And I think that with time, there has been a greater kind of acceptance of the legitimacy of all of these types of problems and the treatment for them specifically. It's a kind of thing that continues to grow. I think that, some agencies and some organizations like NAMI have done a lot to try and help destigmatize, but I think there is a difference between older and younger in terms of how much that's occurred generationally.
Okay. Lisa, you said the psychology of aging can include things like perception and memory. What do people worry about? As I'm getting older, if I represent older people, what are the most common things that I worry about in terms of what's going to happen, what may happen to my mind?
Sure. Memory is the biggest thing that people worry about, and I think that's because of the concern of an individual person that they might develop Alzheimer's disease. And so I think that memory and cognitive functions, so what I call memory and thinking, are probably the biggest concerns that people have.
Are these realistic?
There are definitely some memory changes that happen as you get older. Some concern is certainly realistic. And we do, of course, know that the incidence of getting Alzheimer's disease goes up every decade after age 60. So there are legitimate concerns. I think sometimes, though, that people, particularly when they are first kind of newly old, so in their 60s, start to notice every single little memory failure they have and maybe exacerbate the problem a little bit.
So they're over-interpreting or misinterpreting.
Right.
I forgot my car keys, and that means I must be coming down with Alzheimer's disease.
And I think that there's some research that shows that not just older individuals do that, but other people interpret older individuals' memory failings differently than younger people's. Research showing that the exact same memory failure is interpreted as, an impending sign of Alzheimer's disease in older people, but just, the younger person was busy.
I'm multitasking.
Exactly.
Or I was distracted, or I'm a little bit absent-minded.
Yes, yeah. And so there's definitely some research showing that.
Okay.
I think another issue is that as we age, we increasingly become sensitive to the effect of medication. People are on more medications, they're having more physical problems, and sometimes it's hard to distinguish the effect of a medication from just a sort of natural aging process or a development of a memory problem. There it was. But I think that, it becomes a real kind of challenge sometimes to distinguish these problems. And one of the things that happens too is that as people age and become depressed, which happens a fair amount, then you have some of the same symptoms that may look like a dementia, but actually represent the effects of depression. And so often people are not well diagnosed, and it's hard to diagnose these things differently. and to be accurate in the findings that you come up with. So, understandable, but it's still a problem.
Well, I do want us to talk about depression and aging and what the options are. But the first topic you brought up was medications. And you're absolutely right. I've seen various figures that estimate older people as taking on average anywhere from 12 to 18 different medications.
Right.
But some of these don't play together well.
Right.
They interact, and maybe you could talk a little bit about that and whether some of these interactions can actually produce symptoms that mirror some kind of mental health issue when in fact the person is not that way.
Well, certainly that happens a lot. And, it can happen from just a single medication. There's an awful lot of prescription of medications that are potentially addictive, and that can have a diminishing effect on cognitive alertness and the ability to process information, hold things in memory, and so on. And when you start putting medications in combination, after you get past 2 or 3, really, you have no good research base for understanding how they're going to interact. Because there's just too many different variables. You can't run research that mirrors 12 different prescriptions across hundreds of people. Plus, there are these individual differences in terms of responsivity. And one of the interesting things that's developing is the use of genetic testing to find sensitivities to medications. And in fact, the fact that some medications aren't going to work for some people. So there's all these really complicated things going on. Plus, we have folks who are dealing with, often some chronic illnesses. Pain is a fairly common problem. And pain medication, again, is one of those that can really affect sharpness and alertness and memory function.
So if I have a parent who's 90 years old and taking many medications, and I begin to suspect that my parent might be depressed, or my parent is becoming more forgetful, more disoriented, should I jump to a conclusion of Alzheimer's disease, or should I take my parent and a list of the medications to primary care physician, and where do we start?
Well, I think you've already identified where you might want to start. Getting a list of the medication, having somebody who is in a position, professionally to evaluate the potential effect of those medications is very important. And it's a bad idea to jump to the conclusion that there is a dementia. That's something that obviously needs to be considered in many cases. But sometimes what you're really seeing is more a pattern of depression. Sometimes what you're seeing is sensitivity to medication. And it often it will include as well things like drinking and illicit drug use. A fair number of elderly folks are misusing medication, or using medications that they shouldn't, or using illegal drugs even, alcohol. And once you start mixing alcohol with even prescription medications, you've got yet another interactive effect.
Well, let's take some of these physiological interactions. And Lisa, I want to ask you, it would seem that some cognitive changes, some mental health issues among older people could have physiological bases, and others could just result from psycho-emotional or social events, something like my spouse suddenly dies. What's the balance between physical and non-physical causes of mental health problems for older people?
My understanding is that physical causes are actually pretty deeply entwined with a lot of the psychological problems that older adults face. As Murray was kind of alluding to, there's a lot of physical illnesses that can mimic the signs of depression or memory problems in older people. And sometimes taking care of those physical problems can help out with the psychological. When it comes to the things like a spouse dies, or dealing with the kind of events that happen to us. What the research suggests is that many older people actually are in many ways better equipped to deal with those than younger people are. They've had lots of practice over their lifetime at how to manage their emotions, and so they often can weather the kind of normal ups and downs better than even younger people can. Now, that's not to say that there aren't some older people, of course, who have difficulties. But when you look at the overall picture of healthy aging, usually your ability to deal with those ups and downs seems to get a little bit better.
Okay. Maria, when people think about a psychotherapist, they often think about going into someone's office and talking with someone about my problems, and you have advice to help me solve those problems, and so on. And since you're not a physician, you can't write prescriptions,
Right.
but there are medications that are used to help people cope with certain mental health issues.
Yeah.
So in psychotherapy, there can be a balance between a pharmacological solution and talk therapy. How do you decide what the balance should be? What's appropriate for which situation?
Well, to some extent, it's a matter of how severe the symptoms are. You know, the more severe someone's depression appears, the more likely I'm going to make a quicker referral to a physician for that kind of treatment. If it's more of a middling level kind of depression, you know, we may try some psychological approaches, see how much of a difference that makes. And, you know, partly you also look at the history of the family. Some folks have depression running through the family. They may have responded, the father may or mother may have responded well to an antidepressant. Sometimes that's a cue that maybe that would be useful in this situation. In the more minor patterns, you would typically not refer for medication. You know, the medications tend to work best for the more severe patterns anyway. And the fact is that medication brings with it a variety of costs, including financial cost, potential side effects, and just you know, potential complications from other medications, and so on. So you want to be judicious in terms of how much you really point toward medication as the response in a given situation. And the more severe patterns clearly justify that more readily.
We seem to be a society that medicates a lot,
Yes.
sometimes almost as a default option. Lisa, if I'm worried about my memory, I'm starting to forget things. Should my first response be to go to my doctor and say, you've got to give me something, or are there tips and tricks or diet, sleep, whatever?
Well, when it comes to memory, there's not really much that we can give you or a doctor can give you to help improve your memory. You know, for people who are diagnosed with dementia, there are some medications they give people. They're not really effective kind of in the long term. So I would say that, you know, my first response would be, if you think you're having a memory problem, is it exacerbated? You know, you can talk to your primary care physician about it. They can do kind of a quick screener to see if there's a problem and send you for more testing. But if you if you just want ways of improving your memory, what I often recommend to older people is something that they probably don't think about, but to get good physical exercise. When it comes to the research on what improves memory or what helps keep your memory healthy as you get older, I would say that the most reliable research suggests it's actually physical activity that helps the most, more than, say, doing crossword puzzles or things like that.
Okay, so rather than brain games, I should get out and walk a few miles
Exactly.
every day. That improving circulation gets more oxygen into my brain.
And it's not that brain games are bad. It's just that if you're just doing that, there's not a lot of good evidence that that will actually help you. It might help you get better at playing those particular games, but it won't help you, you know, remember better the name of the person that you just met. But more oxygen and blood to your brain probably will.
And the brain is a huge consumer of oxygen. So if you improve the functioning of your respiratory system, your lungs and your heart and so on, you're supplying the brain with the material it needs to really function sharply.
So I think that's a great tip for anyone.
Yeah.
Be sure you get some physical exercise, park in the parking space farthest away from your office and walk. Even that would be helpful.
And there's some research that suggests too that if you do something, a kind of exercise that's kind of complex, so something like yoga, for example, it's not as physiologically demanding as, say, running, but it requires a lot of thinking and learning while you're doing exercise, and that also seems to be valuable.
Okay. Murray, you brought up depression before. So let's talk about depression as a mental health issue for older people. When older people come in to see you and they show symptoms of depression, is this because they were depressed when they were younger and they've lived a long time, or could something have happened recently to make them depressed? How do you find that out, and how do you respond to that?
Well, all of the above. I mean, I've certainly worked with folks who are, in their 6th or 7th decade of depression, and it's just a real chronic issue for them. Often, you may find folks who have been through really traumatic circumstances. They may have been, come up in hard times economically. They may have been deprived of certain kinds of things and, basic nutrition at some point and so on. So a lot of things contribute to that, but there's an awful lot of situational change that occurs with aging. You lose your friends, the longer you live, the more friends you lose. Family members, the people that you've relied on to help keep your bearings in life. I used to rely on my dad to be able to tell me what the names of the birds and the flowers were, and when he died, it was kind of like, now what? And that happens as we continue along. And the shared memories of experiences between folks and relationships is very important. And as you begin losing some of those folks that help share those memories, it's a real challenge for the survivors. And that can be a depressogenic thing, can create depression. It can lead to people feeling, more unhappy. You have other things too, like as people move out of jobs into retirement, they often are faced with trying to figure out what to do with themselves. Typically, this is a bigger issue for men than for women at this point. That may change over time. You also have issues related to family demands. There's a tremendous number of grandparents who are taking primary responsibility for grandchildren. That's a really big responsibility. And then people move, their friends move away, even if they're still alive, and it's harder to access. So all of these things tend to erode the support network and the things that kind of help give us a bit of a chance to deal with the life stresses we face.
So it's almost logical that older people have more reason, perhaps, to be depressed than younger people. But what about treatment, whether it's medication or talk therapy or a combination? Can most depression be treated pretty successfully if the client is willing to do the work?
There's pretty good response to treatment in general. Often, the research will show that the combination of psychotherapy and medication works best for depression. We get into some of the same complications that we were already talking about in terms of medication response for elder Americans and others. And I think, it becomes a more complicated, complex problem with, physical functioning and deterioration and so on. And yet, there is evidence, I think as Lisa was saying earlier, that as folks get older, if you control for things like medical condition and financial status and that kind of thing, the evidence is that we start actually being happier.
Well, that's good to hear.
Yeah, I think it's worth mentioning.
Let's briefly cover one last topic. We've been talking about older people, but what about their adult children? Lisa, any of your work and any of the courses you teach, you talk about intergenerational relationships and emotional conflicts between aging parents and adult children?
We certainly talk about it in class. It's not a focus of my research. I think that, I often joke that when it comes to the psychology of aging, that middle age is probably the least well-researched part of a lifespan. We do, of course, talk about how one of the difficulties with aging parents, the middle-aged people often get crunched between taking care of their parents and taking care of their kids. And there's conflict, too, between, the parents maybe need help, but they don't want to receive it from their children. So that can create conflict as well.
I'm sure we can go into this at great length in another show. But what we found out is that there are changes that happen to the mind as we age, that medicine and science are allowing us to learn more about these things, and in most cases, successful treatment or effective treatment can be attained. The idea that all old people are going to develop dementia, that's a myth, and that these things will happen to us. And also, as people who work with older people, we're not cheerleaders, we're not doomsayers, we're pragmatists, and I hope that's a good thing. Well, I want to thank both our guests, Dr. Murray Hawkinson, Dr. Lisa Emery. That's our program. Thank you for watching. Please join us next time on AgeWise.